Okay, so now we got a feel for what ECGs are like. Acute coronary syndromes. So ST elevation myocardial infarction means that there is a transmural injury, likely due to complete occlusion. Your pathology textbooks may tell you that STEMI means complete occlusion per se. Sure, it's likely due to it, but since we already told you and explained to you how the terminology came historically to be, and it is an epidemiologic, strictly electrical definition, STEMI means transmural injury. Non-STEMI means there's clear and evident damage to the heart or myocardial muscle. Partial is usually to the subendocardial area, so likely incomplete occlusion. It may respond to initial phase of medical therapy. That's why in those patients we give them medical therapy, because if you have a thrombus, you really don't want to cannulate unless it is complete occlusion or likely to be complete occlusion to prevent embolization. So you stabilize the patient with meds, then a day later or so you take them to the cath lab. You see why we continue to keep those terms? Because they're important. They make a difference on the outcome. They make a difference on the disposition of the patient. An acute ST elevation myocardial infarction is an event in which transmural myocardial injury results in myocardial injury or myocardial death or necrosis if untreated. And so that's just is what it is. It's the most serious ACS. The concepts that needs to be redefined, maybe the differential of myocardial infarction from myocardial injury, those are the ones that were recognized and picked up by the task force, and they clarified those clear differentials. But then, although they realized that that's what was needed, they kept this spectrum of diagnosis, and not to mention that this has become a worldwide convention, so we left it. So what is unstable angina? Okay, so unstable angina is a term used clinically. So what it means is this patient has no electrical changes, period. So if no electrical changes, what am I going to call it? So you would call it non-STEMI and non-STEMI at the same time, right? So there's no STEMI and there's no non-STEMI. But inside they said, okay, well, what's actually happening is a patient coming with pain that is suggestive of an unstable angina. It's like, okay, let's just call it unstable angina. So an anginal pain usually are precipitated. They're usually precipitated by exertion and relieved by rest and relieved by nitroglycerin, a vasodilator of the coronary arteries. So the patient becomes unresponsive to rest and vasodilation by nitro, and they continue to have pain. That means the pain has become unstable. And the chest pain related to the heart is literally called angina, and that's why this entity is called unstable angina. So those are a spectrum of electrocardiographic changes in acute coronary syndrome, STEMI being the most serious because it is usually correlating to a complete occlusion that really needs to be opened ASAP. You need to reperfuse the heart, or there's no way blood will come in the sufficient amounts that would keep the heart living. And so you try to reverse it. And so you automatically know that although we call it MI infarction, not all of it may actually be infarcted. It might still be viable. It might still be ischemic only. So you'd find that a lot of us use the word infarction ischemia interchangeably, although the pathologic definition is strictly different. And then you'd want to also preserve, because almost all of those patients will have myocardial death at some level. Some of it recovers functionally completely. That means there's no residual functional deficit, but you cannot say that there was no tissue death whatsoever. There might still be some tissue death. And you want to prevent that propagation. So you want to limit the damage. So time is money. Time is muscle. Time is muscle. And so STEMI, most serious, non-STEMI, you have electrical changes, but those electrical changes can be anything as long as they are not ST elevation. And unstable angina means no electrical changes. So the definition is still electrical, but it just means that there's no electrical changes with the symptoms, with the same symptoms. So all of them can present with the same exact symptoms, but different ECGs. And then you do a step further and do the biomarkers. These two will always have positive biomarkers. This one won't. So what if this one has no ECG changes but positive biomarkers? We promote it to non-STEMI. So the definition would strictly be non-STEMI. Is that clear? All right, so this is why I told you it's a transmural issue from an electrocardiographic perspective. When you have a damage to the muscle, that means it will be unable to depolarize because it'll be unable to repolarize. So it'll remain depolarized because the ATP dependent channels, they need energy, they need blood to come in, they need oxygen to work. They can't work anymore because they're not getting enough oxygen. They're not getting enough energy. And so that muscle would remain depolarized. So while the other muscles have repolarized, this muscle would still continue to send signal away from it because it is relatively more positive. And so you would get an ST elevation. The opposite happens to the ST depression, where in the repolarization phase, the electrical charge should already be going away from you, should be repolarizing to the resting membrane potential, but then the subendocardial tissue is depolarized because it cannot repolarize for the same reason, because it can't get ATP. So it sends signal both towards you and diffuses around. And so you get ST depression. So that's basically the main concept. Injury current flowing from the depolarized ischemic regions to normal regions is the idea. So this results in the appearance of the ST segment elevation or depression. And so an interesting thing that I want to just kind of like pick your brain on and make you think is subendocardial ischemia will cause ST depression. That is technically demand ischemia because there is angina with exertion and the coronaries are not completely occluded in the strict classic definition. But what is the most distal area of the muscle away from the larger vessels on the epicardium? Well, the endocardium. It's furthest away. It gets the smallest vessels. So if there is any stenosis or narrowing in the muscle that's likely to be damaged the most due to a very much anatomic stenosis, so this is type 1 MI, but it would still be demand ischemia because it's not a demand-supply mismatch like type 2 MI. So I intended to put this slide and to say this message specifically to make you think and to kind of try to confuse you a little bit. Because if you understand such concepts, then the whole idea of MI becomes much easier to tackle in the future. The transmural MI is the ST elevation. So you should be able to ask yourself, shouldn't we call it then, instead of saying ST elevation, non-ST elevation, subendocardial and transmural? The answer is we can, but clinically it's not accurate because you cannot be sure that that's what happens because clinically you can only see ECG changes, and the same ECG changes will occur even in endocardial injury, even when it is not MI due to other causes. And that includes inflammation, contusion, whatever we mentioned before. And so you're required to recognize the entity, call it acute coronary syndrome, treat appropriately, resuscitate, stabilize until you rule acute coronary syndrome out, because it is the most important syndrome there is. And so that would be when we go on to talk about an entity known as silent MI. So any one of the following criteria meets the diagnosis for prior or silent MI that went unrecognized. Abnormal Q waves with or without symptoms in the absence of non-ischemic causes, imaging evidence of loss of viable myocardium in a pattern consistent with ischemic etiology, or pathoanatomical findings of a prior MI, like in post-mortem exam or post-transplant. That's why I will say in post-mortem or histopathologic, because now with advancing science, we do transplants, so we get to get diseased hearts out, but the patients are still very much living because they received a new heart. And so this is an example of imaging. That's myocardial perfusion imaging, and it is showing moderately severe anterolateral wall ischemia. Let's take a case scenario. A 25-year-old female, she comes in with chest pain. The chest pain is only 3 out of 10, and it's stabbing in nature, and it's localized to a pinpoint in the chest on the left side here, and no clear exacerbator or relieving factors. ECG, normal sinus rhythm, otherwise normal. Serial ECGs have been done every 20 minutes and shows no dynamic changes for, say, about 3 hours. A set of troponin was sent, and it is negative. Single set. Is this an MI? So the patient had atypical symptoms, but she had symptoms. the ECG is normal, so there's no electrocardiographic. So if this is acute coronary syndrome, we're already talking about a potential unstable angina. We send for troponin because if troponin is positive, then we can upgrade it to non-STEMI, right? Troponin is negative. So the question is this MI? In other words, is this unstable angina? The answer here is look for other causes, because it is very much unlikely, because the risk of the patient, the presentation of the patient is completely not suggestive of MI. So you'd look for other causes. If you found it, there's no need for any other extra investigation. If not, you stress test the patient, whether before discharge or after discharge from the emergency room, and then you can rule out your MI. So you can't just say, not MI, bye. It's not an MI, goodbye. You can't say that. You have to have an approach to ruling out MI, even if it is very unlikely. A 25-year-old female, same lady. She comes in with a chest pain, stabbing in nature localized to a pinpoint location on the left chest, severity 3 out of 10, no exacerbator or relieving factors. ECG in this case is in sinus rhythm with hyperacute T waves and anterior leads. Serial ECGs done every 20 minutes show changes in V1 to V3. V1, V2, V3 have changes in the amplitude of the ST segment. And none of it is meeting ST segment elevation definition, of course. Troponin is still pending. Can you rule out MI? The answer is absolutely not. So this is an MI until proven otherwise. But the symptoms are atypical, but it's so unlikely, but it's pinpoint, but it's not typical angina, but it's not going. Doesn't matter. Does not matter. This is how you approach MI. We already said you have 3 pillars. You have the electrocardiographic, the enzymes or the biomarkers, and the clinical scenario. The clinical scenario, well, she has pain, but it is not suggestive. So the clinical scenario is a questionable scenario, which means that you need to elucidate by risk stratifying if everything else is normal. If now you have ECG changes that are not normal, so there is dynamic change, and this is another message, or the objective of this slide is to tell you if ECG is dynamically changing, that is suggestive of an ongoing pathology. So it is suggestive of MI. If troponin comes back positive, then this is a non-ST elevation MI and needs to be treated as an MI. Let's now talk about diagnosis. So the diagnosis is based on clinical presentation, is the reason why you think of MI in the first place. Someone comes in with chest pain and you think about MI. Someone comes in with chest pressure, you think about MI. Someone comes in with shortness of breath, you think about MI. And I'm not joking. You think about MI and all of those. When you find a clear and definitive other cause and say, okay, it's not MI, otherwise you have to go through the proper investigation. Be careful not to miss an MI because you thought it is not likely or you didn't think of it. You cannot not think of it. And why is that important? Well, because there are patients who are neuropathic diabetic. Some of the female patients have atypical chest pains. And remember that from your medical school and probably the first time you ever studied about MI, you should remember that you were taught that females, when they have an MI, they are less likely to have it. Sure, being a male is a risk factor, sure. But when they have an MI, they have higher mortality. And I wonder how much of that is because of late recognition and late intervention. So yeah, that is really important. So some of the patients, again, the neuropathics, the diabetics, females, they might have atypical epigastric or even lack of pain altogether, might have just a little bit of chest tightness or shortness of breath. So pressure. Doctor, I feel pressure. Okay. Classically, in old series, 20% of MIs in some old studies have gone unrecognized because of atypical symptoms. So we try to avoid that in a systemic way by changing the way we recognize the potential MIs just by hearing about them, just by seeing the patient. Okay. So diagnosis. Step 1 is the clinical picture, as we just mentioned. If it's typical angina with typical associated symptoms, that's awesome. That's all we need, right? So typical angina, pressure, tightness, retrosternal chest pain running to neck and jaw and shoulder and biceps, associated with dyspnea and sweating, diaphoresis, nausea, vomiting, palpitations, and lightheadedness, that is almost MI. You almost don't need anything else. You do the rest just for completion until proven otherwise. Diagnosis step 2 is your physical exam. Why? Because physical exam increases your risk stratification, increases your likelihood ratio of an MI when you have a physical examination that is suggestive. And so let me look here. So signs of ischemia include an S4, new mitral regurg murmur, having a signs of heart failure, all of them, the JVP, all the stigmata of heart failure, can have, especially in acute phase, and someone has symptoms of chest pain and then stigmata of heart failure. That means the muscle is not working. It's not receiving the right amount of supply. Having crackles in the lung field, hypotension, all of that is related to heart failure. And then having atypical symptoms, including nausea, vomiting, and epigastric pain, is more common in females and diabetics and neuropaths. So you want to keep that as also part of your associated spectrum. Okay. Signs of vascular disease in the physical exam, all of it, peripheral vascular, hair distribution, etc., is also important in your in knowing that that increases your risk for an MI. And so when you present a patient to your attending or senior with a myocardial infarction, you want to tell them their sex, because being a male is a risk in MI. If they're diabetic, hypertensive, smoker, because that increases their risk of vascular disease. And if you want to tell them if they're on an increased stress state, they have an autoimmune disease, they have chronic inflammation. You want to tell them if they're obese. You want to tell them if they have family history, especially in males less than 65 and females less than 55 years of age. Males less than 55, females less than 65 years of age, and a first degree relative. Those are very important and classic simple questions on a physical history and physical exam that give you an idea of the risk of your patient and gives you an idea of who to admit and who to risk stratify further by doing images and stress tests and things like that. Okay, so this slide, I put this slide so that you should learn some of the abbreviations we use in cardiology. So ECG, so some of the diagnostic studies we do, as we said, electrocardiographic and biomarkers. Then with the physical exam and history, we're going to know if the patient is low and high probability, then proceed with other tests. Okay, so ECG, TWI means T-wave inversion. ST refers to the T segment. Collectively, if you have hyperacute T waves or inverted T waves, it's also pathologic abnormality. So we collectively call them STT changes. LBBB means left bundle branch block. So new LBBB is a STEMI equivalent. So there is a whole group of diseases known as STEMI equivalents. I'm not going to dive in that now, but they are treated as STEMI. Hyperacute T wave, TW means T wave. Q wave is Q wave. PRWP means poor R wave progression. Okay. Troponin is mainly what's used now, and we prefer high sensitivity troponin because you can use it in a faster array. You don't need to wait many hours, and it is very much more specific and sensitive. CKMB is gone. CK and CKMB are going out of fashion very quickly. So if everything is normal and there's only symptoms and the symptoms are not typical, so the patient has low probability, now you can go ahead and do a cardiac stress testing or a CT angiography. There are limitations to each. CT needs a control of heart rate. Cardiac stress test, if it's physical, you need to make sure that the patient tolerates it. Otherwise, you're going to use chemical. And you look for new wall motion abnormality. WMA means wall motion abnormality. You see that on TTE, that's transthoracic echocardiography. That's the ultrasound we use on the chest to look at the heart. It's a non-invasive, no radiation. It's an excellent, almost risk-free test, very safe, non-invasive strategy. And we also have TEE, which is a more invasive, transesophageal. So in an endoscope, we do an echo. That has almost no role in the acute coronary setting. You don't have time to waste doing such procedures. If you want to do a procedure, it's going to be a coronary angio. So you can definitely go to coronary angio, take the patient to the cardiac cath lab and diagnose them with a diagnostic coronary angio, and then you can turn that procedure into a therapeutic procedure. If you saw stenosis, then you can change your wires and go in with a guiding catheter, put your tools inside and open the coronary. And that we call PCI, primary percutaneous intervention.